let's jump right in. Today, we're giving you a super high-yield update on hypertension management, and we built this specifically for you, the practicing endocrinologist. We're going to cover everything from the core foundations to the brand new therapies that are literally changing how we think about blood pressure.
Okay, let's start with a number that really sets the stage for our entire conversation. Just 21%. That's the percentage of adults worldwide who actually have their hypertension under control. Think about that. It's a massive, massive gap, and frankly, it's one where we as endocrinologists managing these complex patients can make a huge difference.
So, here's our game plan. We'll start by digging into why that control gap exists. Then, we'll build up from the basics of modern therapy to how to crack those tough, resistant cases. We're going to spend some real quality time on the obesity-hypertension connection that's so key for your practice before we look at the exciting stuff in the pipeline and wrap it all up with your key takeaways.
So why is that 21% number so stubbornly low? I mean, it's not like we're short on effective medications, right? Well, the problem is a bit more complicated, and it's a series of challenges that, we all face every single day.
The evidence really points to this trifecta of issues. First, there's patient adherence, which is always a struggle. Second, something called therapeutic inertia, that hesitation to step up treatment when we're not at goal. And finally, you've got these bigger systemic policy issues. So yeah, it's way more complex than just writing a script.
So let's talk about the first step on the clinical ladder. How do we build a really solid foundation from day one so we can try to avoid all these problems down the road? Well, it all comes down to how we start.
Look, the evidence here is it's overwhelming at this point. The old way of doing things, starting one drug, waiting, inching the dose up, it's just obsolete. Starting with a single pill combination therapy gets your patients to goal faster, it gives them better control in the long run, and you just get a bigger bang for your buck in terms of blood pressure reduction.
And this isn't just about the numbers on the cuff. The landmark ACIA-POLISH trial gave us the hard data. It showed that combining an ACE inhibitor with a calcium channel blocker, like amlodipine, led to a 20% lower rate of major cardiovascular events compared to using a thiazide diuretic. That's a real-world, life-saving benefit we just can't ignore.
Now, speaking of diuretics, if one is part of your plan, you gotta know that not all thiazides are created equal, not even close. Chlorthalidone is way more potent than HCTZ, but look at that half-life. 40 to 60 hours versus 6 to 9. That massive difference gives you smooth 24-hour blood pressure control that HCTZ just can't match.
Okay, let's climb up to that next level of complexity. The patient we all see in our clinic, the one whose blood pressure is still high even though they're already on 3 different meds. What do you do then?
Before we even think about adding a fourth drug, we have to ask a crucial question. Are we dealing with apparent resistant hypertension, which, let's be honest, is often just an adherence problem, or is it true resistant hypertension, where the patient is doing everything right and we're still not winning? Figuring that out first is absolutely critical.
So here is your game plan, your evidence-based playbook. Step 1, you have to confirm they're taking their meds and double down on lifestyle. Step 2, if they're on HCTZ, switch them to the heavy hitter, chlorthalidone. Step 3, add spironolactone. And step 4, and this is your bread and butter, you have to screen for primary aldosteronism.
Now that decision to add spironolactone, it's not just a guess. The Pathway 2 trial basically settled the debate. It went head-to-head with other add-on drugs and found that, spironolactone was hands down the most effective. It's the clear, evidence-based fourth-line agent, period.
And for you, as endocrinologists, this is huge. Why do we screen? Because in this specific population of patients with resistant hypertension, the prevalence of primary aldosteronism is as high as 20%. This isn't some rare zebra. It is a common horse, hiding in plain sight in your clinic, and it gets missed all the time.
Okay, now we pivot to what is arguably the core of this whole conversation for your specialty. We're moving beyond the traditional BP meds and into this powerful intersection of metabolic health and blood pressure. This, right here, is where the field is going.
So here it is, the big idea. We are in the middle of a massive paradigm shift. We're no longer just chasing a symptom, the high blood pressure number. We now have rock-solid evidence that treating the root cause, the metabolic driver, obesity, with drugs like tirzepatide is a direct, powerful strategy for treating the hypertension itself.
And we've got the receipts to prove it. A sub-study from SURMOUNT-1 using 24-hour BP monitoring
found that just the 5 milligram dose of tirzepatide drops systolic blood pressure by a placebo-adjusted 7.4 points. I mean, come on, that's as good or better than many dedicated blood pressure pills.
But here's the kicker. This is the how. A full 70% of that blood pressure drop was directly mediated by the weight loss. It's not some weird off-target effect. It's plain and simple. You treat the obesity, you treat the hypertension. The link is undeniable.
So where is all of this heading? Let's look over the horizon, because beyond these amazing metabolic drugs, there's a whole new class of antihypertensives in the pipeline designed to handle even the toughest cases.
Okay, here's a quick snapshot of 3 of the most promising ones. You've got aprocitentan, working on endothelin receptors. Then there's lorundrostat, a new aldosterone synthase inhibitor that posted a really impressive 9.6 millimeter drop. And finally, zilebesiran, which uses a totally novel approach. Just take a second to look at those findings. But let's really zero in on zilebesiran for a moment, because this is a whole different beast. It's a small interfering RNA therapy. Basically, it's a message that tells the liver to just make less angiotensinogen, a key ingredient for high blood pressure. One shot, under the skin, can control blood pressure for up to 6 months. Think about what that does for the adherence problem we talked about. It could solve it.
So, let's bring it all home. We've covered a ton of ground, from the fundamentals all the way to the cutting edge. Let's boil it all down to the key things you can take back to your practice tomorrow.
All right, here are your top 5. 1. Start with a single pill combo, ideally an ACE or ARB, plus a calcium channel blocker. 2. For your resistant patients, spironolactone is your evidence-backed 4th agent. 3. Screen all of those resistant patients for primary aldosteronism. 4. Embrace the new paradigm. Treat obesity with drugs like tirzepatide as a first-line strategy for lowering blood pressure. And 5. Keep your eyes on the horizon because these new aldosterone synthase inhibitors and siRNAs are coming, and they're going to be game changers.
And I'll just leave you with this final thought to chew on. As these incredible metabolic therapies and long-acting agents get better and better, are we heading for a future where the main tool we use to treat hypertension is found in a syringe and not in a pill box? It's a pretty exciting time to be in this field. Thanks so much for joining us.